brought this topic up to me a little while ago, and I was like, that's brilliant. And, let's get a world-class thought leader and researcher, have absolutely a thought leader, supply chain provider, and then a very customer-focused commercial manufacturing guy on the phone to discuss this. And that sounds like the start of a bad joke, but absolutely great panel here to chat and discuss this and share the anecdotes and what we're seeing in the marketplace. And please, I would encourage you to send in questions to Dennis, and we'll try and get to them as many as possible. And what I'll do is I'll be pulling in both Gary and Gray into the conversations as well, so that we can really make this a conversation and a fireside chat rather than a single directional presentation. So with that, I'll hand it over to Sarah.
So hi, everybody. I'm so pleased to be back in the SMI group. And I feel somewhat passionate about this topic. It fits into the sort of spectrum of value-based care strategies, and was actively involved in the research, and so was able to sit in on and participate in many of these conversations. So, all right. Now I'm trying to move the screen forward, and I'm having a little trouble. All right. I'm going to give the presentation back to you, Dennis, because I'm not able to move the slides forward. Seem to be stuck.
Dennis, maybe you just move.
Oh, here, wait, no. As soon as I created an emergency, now we're able to move forward. All right, sorry, everybody.
Okay, Sarah.
Isn't that always the way it goes? All right, so I guess I wanted to start by saying so let's start with defining a little bit with what bundling is. I can get into more depth about that as we go on, but just to make sure everybody's on the same page. So bundling is what I would call one of many of the different value-based care strategies. It's different from fee-for-service, obviously, because you're not paying for each service provided. In fact, you're trying to gather up services that are related to each other and pay for them together, with the incentive being to providers, if they can save some money in somewhere along the line, then they are able to keep it. And that's the notion. It's different from total population health because it's triggered by a hospitalization. So what was our major finding? The major finding was that organizations were able to find meaningful cost savings, mainly around reducing skilled nursing facility care. And what I found so fascinating in these conversations was that it really was about changing the incentives, making hospitals and physician groups at risk for health care after the hospitalization, and providing data that organizations had the reason to be able to find these savings opportunities. And they did. They looked at patterns of care. They went after high-cost SNFs and began to sort of narrow the network of organizations to whom they made referrals. And we heard a lot of stories about working with physicians as well. Data were critical. I think that's a takeaway, and the analytics to understand the patterns shown in the data to identify opportunities. All right, so let me give you a little bit of background. As I said, bundles fit in the spectrum of different value-based care activities. I'd say they're nicely right there in the middle. And one of the attractive things we heard from our interviewees is that you can get into doing bundles without fundamentally turning over your fee-for-service revenue focus. So because you get paid for the hospitalization, right, you don't have to worry about cutting off your nose to spite your face. So under ACOs, hospitals that take on full risk actually lose money on the fee-for-service side if they're successful on the value-based care side at reducing hospitalizations. With bundles, that's not the problem. You get paid for the hospitalization and you get paid for a period of care of time afterwards, so you can find opportunities after the hospital stay to reap those savings.
Sarah, so what are you seeing with all the activity that's going on in DC around rethinking ACA? Where do you see bundling falling into that discussion?
So great question. Thanks, Hussein. So my best understanding of what the new Secretary of Health and Human Services thinks about value-based care is that he's mildly supportive as long as it's not creating a huge hassle and challenge for physicians in particular. I think he's very sympathetic to physicians, being a physician himself, and has been very clear. He just said this in both his hearing and earlier, that he's not in favor of mandatory pilots. So the specific pilot we looked at around bundles was a voluntary pilot. I do think that there will continue to be some forward movement around value-based care, bundles, ACOs, various forms of patient-centered medical home, but I think it won't be quite as aggressive and it won't be quite as passionate, and there will always be a sympathetic ear to physicians if it's overstepping the line.
And today, if you take a look at the spectrum that you have on the screen right now, you have companies across the spectrum.
That's right.
Are there particular groupings around a particular strategy that you see more than others?
I do. So there's definitely about 500 health systems that have tried the shared savings approach, and that would be under MSSP, which is the initiative that's sort of the starter ACO version. We saw quite a number of organizations participate in bundles. Shared risk has been less popular. It's scarier. You have downside risk as well as for shared savings. And capitation is not as common. It's very common out on the West Coast in California. We see organizations that have been subcontracted to health plans out there that are eager to take on full risk and to get even more savings that way. So I'd say that's a market-specific set of activity. Much less common in other parts of the country. So the BPCI, which is the bundling program we looked at, the design gave organizations 4 different options. They could, and I'll give you a graphic that brings this home. The most common choice among participants was to go after the definition of the bundle that covered the most services. It includes everything from the acute hospitalization all the way through any readmissions and post-acute care, and they could pick a length of time after the hospitalization to be at risk for. Much less common were some of these other models. I'll give you a little another example of this. So apologies that the colors changed, but Model 2, which is this most common version, is on the top. And you can see that actually even within Model 2, the most common choice of the defined bundle was to go with the longest period of time, 90 days after the discharge from the hospital. And so you can see there were 110 participants, and it was a combination of hospitals and also physician groups that participated in this model. So what did we find? We had really rich interviews, and we talked not only to health systems, but we talked to organizations that are helpers to those organizations, like Remedy Partners, the American Association of Medical colleges, and we talked to health plans, which are interested in bundling as well. Had a little less opportunity to talk to physicians, although we did talk to a couple of physician groups, mainly orthopedic surgeons. So why are they getting into bundles? I think that we heard again and again that this was maybe the easiest way in. Not to say that bundling is easy. We'll talk a little bit about some of the challenges, but I think organizations saw this as a pretty good way to get started. We heard from a major health system that has multiple for-profit hospitals across the country, and they said, you know, we're not sure about fully investing in value-based care, but we did feel that this is one where it made sense for us to get started. So we heard that refrain many times. There's also a chance to learn, even though this was just one type of pilot, I think it had a lot of lessons around how you need to organize your care, how you have to set up your analytics, and organizations thought that this would be a way to maybe expand and learn that they could take other opportunities. There were a few organizations, including a major health system in Pennsylvania that's well known for its work in being an ACO, that actually are doing bundling as well, and they saw this activity as complementary. That if you could get some savings through one initiative, that might spill over to savings in another initiative. I think there was a lot of interest too in positioning and showing CMS that, you know, my health system is willing to participate and be a part of this new generation of care. And finally, last but not least, everybody told us that this is the way that they saw to gain alignment across the hospital, health system, and clinicians, especially specialists, which are very challenging. We did a separate analysis a couple of years ago looking at the role of specialists and ACOs, and the punchline there is not much. Bundling, because it's around particular conditions that are specialty in nature, is a way to engage the specialist to a greater degree. So what strategies did we hear were important to be successful on value-based care? So number one, absolutely look at the data. It's amazing how organizations, mostly health systems, that really have not had a reason to understand who they were referring to. I mean, a lot of organizations think about, you know, helping with convenience and access. There might be long-standing relationships, but they're not drilling down on readmission rates. They're not drilling down on quality measures, and they're certainly not, you know, looking at length of stay and that kind of thing at these skilled nursing facilities. And, you know, investing in the data and the analytics is critical to be able to find those opportunities and also to understand whether they're on track relative to the benchmarks in order for CMS to give them the additional payments that they would win. That was key. Everybody went after skilled nursing facilities, and we did hear some examples of going after inpatient rehab facilities that vary by part of the country where there are inpatient rehab facilities. We also heard about going after readmissions, and there were a few cases where we heard about trying to reduce costs inside the hospital stay, but that was much less common. And then, you know, no surprise to anyone, engaging the care team, and that started with physicians and the specialists, but it also included the hospitalists, the nurses, and absolutely the discharge planners. And then the patients themselves. We heard again and again that some patients just sort of expected to have a skilled nursing facility stay after their hip replacement. Parts of the country like Chicago, their advertisements that say, hey, we have really good food at our skilled nursing facility, come and give everybody a break and recuperate. They had to do some work to set expectations with patients, like, for example, saying, we're going to start doing rehab before you even have the procedure. We're going to get you out of bed in the hospital. You may be able to go home and not even need to go to skilled nursing facilities. So working with the patient and their expectations and the patient care teams was important.
So Sarah, I'd like to go back to the first point you made around investing in analytics and other technologies, because, you know, that's spot on, and every provider that we have a discussion with, even some of the more sophisticated and mature ones, are battling with, you know, what metrics should we use? How do we standardize this? I mean, the data is just enormous. It's like, you know, you could boil the ocean here many times over. What are some anecdotes that you were seeing in this space, or what just go a little deeper in this area?
So number one, we heard readmission rates. So skilled nursing facilities actually have a lot to do with whether they're readmissions to the hospitals. So that was number one. Number two, we did hear about SNF length of stay, because if you can shorten that length of stay, you get the savings. And number three, we heard about using the CMS quality measures as an indicator. We also heard that those were not great. that they're really designed for people who are trying to find out a good long-term care facility, so lower bed sores and that sort of thing, not as relevant for the largely orthopedic surgery patients, where really the metrics should have been around, gaining function. So I think we heard some constellation, some sort of agreement around some of these measures, but also that they don't go far enough.
We had a question from the audience around bullet point number 2 about reducing the skilled nursing facilities. Did it impact, or did reducing SNF impact quality of care? I
have a slide, stay tuned, that speaks very much to that question.
Brilliant.
So if you can hold that question, we'll get there pretty soon. So let's talk about what we heard about what some of the challenges were. I mean, we didn't hear from anyone that this was a slam dunk. First of all, they had to roll up their sleeves and do the analysis and begin to think about care in a different way. We certainly heard about needing to work with discharge planners in a new way. We also heard about some challenges in working with CMS. I think a common refrain was not getting the data quickly enough, not getting the data in enough granularity. We also heard about financial challenges. I think that it takes some investment in order to be able to have the systems and put the changes in place. And even though we saw a lot of examples of where there were savings, they weren't huge, right? So there's definitely a balancing act between targeting the opportunities and not overcommitting, because it is, after all, a pilot for only a set number of conditions and not overdoing it. And then, I think even though maybe I could say that bundling is sort of a logical first step into value-based care, it is a change in perspective. You're thinking about your patients in a different way, and you're thinking about following them over time, and it's hard to create those cultural shifts.
So, Sarah, by no means do I want to undermine the importance of the financial piece and incentives or the infrastructure that's required to do this. But, culture is, as you know, it's something that's very, very close to my heart, and I think that's going to be the hardest and perhaps the longest battle that we'll have to fight to be successful here. Any thoughts on that?
For me, I think, engaging physicians was important, and getting them involved at the beginning was really key. I mean, I think that cultural change starts with that, and I think it's really notable that, these programs have focused on orthopedic surgery, where, it is a very transactional kinds of service. Showing them the data, I mean, physicians are analytic people, and understand numbers, and I think that we heard that again and again, that sharing the data, being transparent. We did hear some examples of changing incentives and reward systems for those clinicians, and I think that the data, the engagement, and the incentives in making the physicians part of the solution were critical to changing that culture.
Great. Are you on? Are you on? Can you unmute? Sure. I'd love to get your viewpoint onto this. Great. Culture is all what you're about. So I'd love your viewpoint on what you're seeing from a cultural perspective.
Yeah, you bet. Thanks, Hussein. I've had the pleasure of moving into a variety of different markets, and always starting out with culture and understanding its contribution to success. And I have some thoughts on the transactional piece that was mentioned earlier, but I think specific to your question, we were talking about this last week in preparation for the call, and Gary made a good point. He said there's definitely a piece of consumerism that's here, and I think that the revolution that's happening to healthcare is no doubt a result of consumerism, but that doesn't necessarily help, with the successful implementation or execution of something like this. And I'd like to just offer up that never forget that there's an opportunity to brand culture wherever you go. We sort of have a joke when you talk about culture. You always ask somebody what they like about the culture, or what they don't like, and it's hard to ever put your finger on that. And so I'll use an example here. And Sarah, I loved your white paper, but I'm going to point out a few things. There was a piece in there about engaging the care team or finding a physician champion, and I'll just offer some of my own anecdotal advice here. I think the number one piece about culture when you're walking in to do something different is changing the vocabulary. And I say that because every single one of us have, we have definitions of certain words in our head that we've had for a long time. And my point there is accountability is a good word. It's a word that's unfortunately too often used, and all of us have a definition of what that word means. And so if you're in charge of implementing this or trying to get after any of these BPCIs or any of this change in practice, I don't think you stand much of a chance if we're using words that people have longstanding definitions for. So good example here, go back to the engage the care team or the physician champion. This is really hard. You do have to roll your sleeves up. And those terms don't suggest anything very different. And so if I could offer it up, if you branded this culture from the start as a culture of aggregation, the minute that that's on the table, you're going to have the physician champion or the care teams start to ask questions. And once they ask questions, I think you'll have much more of interest and buy-in versus, okay, this tastes different and smells different. What do we need to do different? I realize it's a semantic, small difference, but I can tell you, working in a variety of different markets over the last 15 years, that's the best way to start off and prepare yourself for success. Just one simple change is think about how you want to brand your own culture as you set off into this big task.
Brilliant. Brilliant. Gary, anything to add?
Not at this point. When you get rolling on this, I do want to come back to consumerism though, because I actually think I think this serves as I think bundled payments or these alternate payment structures are going to serve as a catalyst for a lot of change related to consumerism. And let's leave it at that. Let's keep rolling, and then we'll come back to that.
Brilliant. We have a question here, Sarah.
Yep.
And it sounds like the discharge planner is critically important in the process. Is that true?
I'd say yes and no. I'd say yes and no. We did hear about situations where organizations had worked really closely with their discharge planners, and others where they basically did an end run around them, working instead with the clinicians and giving them a list of, I mean, obviously there are rules about giving beneficiaries choice of post-acute care facilities they can go to, and that needed to be adhered to. But in some cases, you saw examples of organizations that ended up just sort of taking over the discharge planning function rather than having the hospitals have to retrain their discharge planners. So I'd say yes and no.
And what cultural changes occurred for patient selection?
I think that was really something we heard again and again, that it was really important to, at the very beginning, understand whether particular patients had comorbidities and risk factors and were not good candidates to have reduced or changed patterns of care based on what the typical traditional would be. I think we heard that again and again, that being able to identify patients with the comorbidities and sort them out from the patients who were likely to get better faster or had more home support, frankly, was important. So I think understanding at the front end, what the potential care trajectory could be was really important. So patient selection absolutely was something we heard about. We did hear about one, investment that organizations have made into actually, plugging some of the patient characteristics into some kind of a predictive modeling approach and using those results. But I think that was less common than, just using some clinical guidelines to be able to sort people into different groups. All right, thanks for those questions. So I did want to share with you, this has been a program that's had a couple of deep evaluations from a third-party evaluator. share some of the findings from those. We did hear that most of the savings came from post-acute care, and that was absolutely borne out in the formal evaluation. Also, that most organizations chose hip and knee replacement as the bundle to go after. We heard that organizations that had tried some of these more chronic care conditions had had a mixed success. We heard again and again that some of the challenges were that you don't always know what the final discharge diagnosis is going to be and whether that qualified for a bundle or not. We also heard that it's important for these chronic conditions to have really good care coordination, and also that it's harder to target that care coordination as well without spending too much money on care coordination and not enough on savings. So I thought that was interesting.
Hey, Sarah, this is Greg, can I jump in here?
Sure, of course.
I really like this slide, and I think this slide is a really good acknowledgement of the question we just talked about from a discharge standpoint. My team spent a lot of time in this kind of BPCI world, and I think the first thing we need to say is you don't have to raise your hand specific to volunteering for any of this in order to find value in the process alone, regardless where you are and what system that you're a part of. But if you look at the selection drop-off here, you go from 75%, the majority joint replacement, to 35% in CHF. And I think, why is that the case, which is something you were just touching on. And the reason it's the case is there's such a cost variation here. Joint replacement, the majority of the cost is really in the procedure. There certainly is some on, where they discharge to, but on the CHF side, the majority of the cost is actually in the discharge and the go-forward disease management of that. And so what does all that mean? I think, more on it later, but joint replacement care pathway is a little more transactional in nature, which allows for a really easier point of entry into the activation and execution of these APMs. Whereas, that delta of 75% to 35% that you see in the slide, I really think is a reflection of less transactional care pathways as it pertains to the patient themselves. And then you go back to, there's more on that, but that equates to really more characterization of the data that you talked about. And I'm kind of getting ahead of myself, but this slide I thought was a really good example of what does that tell us about the clinical episode bundles that were selected, and then how they differ.
Yeah, I completely agree. I definitely, Hussein and I actually were talking about this as we went out to grab a bite before the call, that these other conditions might be the ones that are the low-hanging fruit for population health, for, ongoing care management. But because the bundle is structured to just be the 90 days after the hospitalization, it's not as clear where the opportunities are.
And as you kind of
I would add that, I was just going to say, Jerry, I would add one thing. Maybe I'm just oversimplifying it, but I think from my perspective, looking at this, it goes down to the predictability of what the outcomes are going to be. Whereas a surgical bundle in orthopedics and knee, it's far more predictable in terms of what the outcome is going to be, that there's a certain percentage of those patients will be readmitted, and I think it allows organizations to get far more comfortable with the risk. When you get into categories like congestive heart failure and pneumonia, the predictability and where that could go and where that care can go dramatically changes, and so it just becomes less, the term I guess is, there's a lot more less appetite for going into risk-based contracts of some level on those bundles. And I actually believe that in the long run, as this experiment, I wouldn't even call it an experiment, we move more and more to this type of payment, there's going to be a hybrid model where there's going to be things that fall very carefully that fall into bundled payment kind of structures, and there's going to be others that just will never fit, and probably be some other alternative methods of payment.
Yep.
Okay, I promised I'd talk a little bit about the quality results, and you might have expected that with shorter lengths of SNF stay and some patients going to go home without SNF at all, that you might see worse results. Well, I think what you see here in this chart is, if anything, results were somewhat better under the bundle than they were under usual care. The differences weren't huge, but I think the punchline is patients don't seem to be suffering as a result of getting less post-acute care under this bundling arrangement. So this map here gives you a sense of where the participants in these initiatives have been. You can see the biggest area is that navy blue area around New York, followed closely by Boston and Chicago, and then some across the rest of the country. So they've been tended to be concentrated in major metropolitan areas, probably areas where you have the greater volume of care and the greatest choice of post-acute care providers, because if there's only a few around town, you're not going to have necessarily the same opportunities. So, as APMs become, so alternative payment methodologies become more prevalent, I do think that even in the new administration, we'll see more interest in bundled payments. What do we say to health systems to prepare? So you've heard it already, and I'll say it again, is analytics and data are critical to find the opportunities and which organizations you want to partner with. You want to find the SNFs that are willing to change usual care patterns. Think about different metrics and report to you and work closely. See it as a part of a larger strategy where you can put some systems into place that might be helpful with an ACO strategy, and then improve quality. Although there are not a whole lot of quality measures yet, I think that there probably will be more over time, and this is always a differentiator. I do think we're seeing more commercial health plans interested in bundling. In fact, that was one of the incentives for doing the project, is a number of the large commercial carriers were interested in learning from the Medicare experience and thinking about doing something like this themselves. So health plans are interested in organizations that can come forward and say, hey, we could do bundling with you. So that's a good pointer too. I do also want to take a minute and think about some of the things that we learned relative to the supply chain. I went into the project expecting that organizations were going to say, yes, this made us drive a really hard bargain with the implant providers, with the other suppliers, because we thought we could save money. We did hear in a few examples that that was the case, and that they were designing gain-sharing programs with their physicians, where if the physicians could find savings within the hospital stay, they could share those savings. But by and large, most of them were looking outside the hospital for the opportunities. So I know that we do have some suppliers on the phone and did want to speak very specifically to that.
Gary, I would say the same thing for prior experience at Northwestern is you're spot on. It's been less around the implant costs and so forth. That's been normal business for us on a day-to-day basis, but bundle I don't think has really changed our approach on that from that perspective.
Yep.
So,
hey,
while you yep, go ahead.
I think as it's from a manufacturer standpoint, I mean, as we've dug into this, I agree. It's less about the implant cost, and it's more about outside of that. I do think if you go back to the sort of dynamicism of disease states, right? And Gary made a great point. It's, what can you get your arms around, or where do you take a bite out of this? I think there's a piece of the data construction that's really important. And so if this is a good time to talk about it, or maybe a little bit later, I'd like to.
Go ahead.
Thank you. Since when you look at, everybody on the phone is familiar with the word segmentation, and I think as you know, the data piece is, and Sarah mentioned it's a mountain of it, and it's how do you segment or synthesize the data as it looks to these disease states. And we finally made some headway when we sort of quadrant that data. And so, for example, you know, there's a patient characteristics piece that is specific to everybody's market on the phone. And then there's a clinical outcomes piece that everybody on the phone has as well. And then there's the, well, how much money did we spend to obtain that outcome on those patients, right? And then finally, on that, on both the during the intervention, but also the 90 days post, what were the resources that were used to obtain all of that, right? And so it helps, at least it helped my team and my discussion that we were having of, okay, if we quadrant this out, maybe that helps guide us towards points of entry into these, as I termed it, less transactional disease states. And so whether you are thinking, I want to take on the risk, which Gary made a great point there, or are you thinking the bundled payments thing is my route, I still believe there's opportunity for more efficiency, more savings if you just simply go through the process. And I think these less, as again, manufacturer guilty over here, but it's a great opportunity to exercise and find a partner, you know, a manufacturing partner to find those entry points regardless of how intimidating or large the scope is. And I wanted to make sure that to offer up, you know, anecdotally again, our experience that very much helped to seek entry points into these spots that, to Gary's point, may not be part of the overall process going forward, but certainly a place where you could find savings or better efficiency outside the actual implant. This is a go forward manage of the patient.
Brilliant.
Total cost of care, managing the care from the front end to the back. I mean, I think this is, as I said earlier, I believe this is a catalyst. These bundle payments, as we get into it, are going to be a catalyst for a significant amount of change in healthcare. And I think it's going to drive into a lot of consumerism issues where, I think about a physician sitting with a patient, and there's so much, there's been so much criticism of healthcare, and it's legitimate pricing and what it costs, and the fact that no one can tell a patient, really what the cost of your care is going to be. And I think that bundled payments to some degree just eliminate that and simplify it. You come to Northwestern and you need to have your knee done. Here's what's covered under that: your stay, your post-acute care, and so forth. And here's what you can expect. There is a risk of a readmission. If it is occur within X days, it's still going to be part of the overall price. And here's the price you pay. And there's no ifs, ands, or buts about that. And it accomplishes a lot. And it also puts the physician at the front end of the managing the entire care process. And all these things have to be worked out. But as more and more organizations, I think, start going down that path, then that creates competition, I think, which is good, where you're going to have hospitals competing for price, just like in what you'd find in any other industry, and looking at outcomes associated with that. And as that starts to take hold, you'll start to see more and more change, and it's going to impact supply chain. It's going to impact. It's going to cover so many issues that we've been challenged with in healthcare and given back to what the consumers want. And again, that's my perspective on it, but that's what I see happening probably, and it's going to evolve over, I think, in a relatively short period of time.
So, Gary, I want to continue that line of thought here a little bit, but as you see, and it's a great point that bundled care is going to be a catalyst for consumerism. I totally buy into that. But as you see bundled care capabilities being implemented in your system and other systems that you've been observing, what are some surprises that you are seeing, or what are some challenges that you didn't expect to try and overcome that you're seeing in this space that you could inform everybody on the call?
Well, I was, again, I'm primarily coming at it from a supply chain perspective. So one, I would say from a supply chain, it shifted as came out loud and clear. It became less about the implant costs and less about the hospital stay, and more about the continuum, the costs more on the front end and particularly on the back end with skilled nursing facilities and so forth. Particularly when I think about the orthopedic bundles, which I'm more familiar with, at least from Northwestern perspective. So that's the first issue. Is I thought actually we would see more on the hospital side, and our experience reflects what the study says. The second thing is I think there's a cost of managing these, and that the savings we've seen, I'm not sure if the net savings has resulted in a benefit to the health system, because there's a lot of cost to manage this, and what I'm getting to is the data analytics associated with managing this as we think about it. We're at the early stages, but to do this in a big way and to really manage care effectively, going to require, really real-time type of systems and analytics where you can manage that patient. And I hate to use the term, it's a little bit like a production or a manufacturing production line where you want to be able to track patients on a real-time basis and find out where they're at so that you can manage that cost of care. And we don't have systems in place today that really can do that. And I think the cost of putting those systems in place and changing the way that we think, particularly if we do this on a broader scale, I'm hoping that the savings that we get out of it on the other side will offset those costs. And the benefit will be a benefit to the patient, I think, back to what the consumers want. But I'm not sure yet that we're going to see huge savings out of this.
Mm-hmm. Yep. Interesting. For the folks on the phone, I would continue to encourage you to send questions in. This has been a phenomenal discussion. Gray, I have a thought for you, and Gary just was very eloquent about what he's seeing from a provider space as well as some of the challenges, and going back to the culture piece a little bit. And I'm not trying to be cute here, but I'm trying to be provocative in terms of everybody's thinking. When you and your colleagues see, a customer, provider trying to implement bundled payments, etc., do you see that as a block to you guys? Do you see that as an opportunity to you guys? How do you guys think about it? What's your mental model, and how are you planning to manage this mental model shift in healthcare that's taking place?
That's a great question. And to be completely and totally honest, it's how it presents itself. There is, and again, not trying to be cute either. There's some of this, and Gary mentioned the competition, which is great. If it comes to us with some massive sense of urgency and sort of hair on fire feeling, I like to say I get the feeling that's just more about keeping up with the Joneses. So it's less about bundled payments, and it's more about we might have seen some benchmarking that had different pricing. That goes back to you're more worried about the transactional cost. If it comes in the form of understanding that those bundled payments, or maybe it's not just the bundled payments, Hussein, but the culture is one of discovery. And so, we would like to, I think we make a mistake from a manufacturing point to walk in the door and offer, here's this 4 or 5 different forms of services that we can offer. I think we walk in the door more with you understand this is a discovery process, and I do too. And then we say, well, what are, Gary, the word he used was catalyst, which is great. what are some catalysts that'll really start us off on the discovery process? And we both acknowledge that, I hate to be cheesy, but sort of arm in arm, we're walking together, figuring out where these opportunities exist for more efficient, for total cost of ownership of the patient, or even more efficient uses of our resources. And I'm not trying to overcomplicate the answer, because the answer is a culture one, but from at least our manufacturing standpoint, you can sense if there's this sort of disparity approach of, we'd have to do this now, and that to me is, this is not a quick fix, we all know that, but if there's more of a partnership, and maybe we can help you with that data. The thing about data, the biggest challenge is everybody likes to say they can synthesize data best. I personally haven't found that. I think there are some people really good at it, and then I think there's some people who say they are. So I think the culture piece has to be who's coordinated well after we get through the discovery process. Do they have enough coordination? Does the partnership have enough coordination, both independently and together, to then seek out these opportunities for better approaches that can both, more importantly, provide a better patient outcome, but also spend less money doing that. Does that answer your question?
Yeah, makes a lot of sense. So, Sarah, question for you. I mean, we see the payer response to this, a little bit all over this space here. What are your thoughts about the payer response, or what the payers could be doing to maybe make it a more formidable response, a more helpful response to working in coalition with the value chain, for instance?
So I think health plans can be doing a lot to create additional momentum towards value-based care. We did a study about a year or two ago looking at the degree to which Medicare Advantage plans are involved in some of these value-based care initiatives, and we found that not as much as activity as you see on the CMS fee-for-service side. And I do think that there is a lot of potential for savings from bundling, and I think that if commercial payers get in on the action, that would only accelerate the discovery and the sophistication of the analytics and the finding of opportunities. That said, I think we also need to think about the different population that a Medicaid program or a commercial program have, and you're not going to find the same opportunities. So you don't have as many people getting hip replacements. You do have some, obviously. There's a lot more people having babies, and there's a lot less variation in that care. So I do think there's a lot that payers can do to get on board and amplify sort of the momentum toward change, and absolutely share their data. But I do think that the opportunities are going to be somewhat different because of the population.
Perfect. Gary, we're coming to the end of the hour. Would you have any closing comments, closing thoughts?
Well, I think, as I said, I think the term was used, discovery. I think the bundles are, and these alternative approaches to payment, so forth, we're in a discovery stage. And I really like the comment about data. That was spot on. And converting data into information, and organizations' ability to manage that effectively, I think, are game changers, are what will differentiate hospitals. I know one of the things we talk about at Northwestern is that we believe that the value proposition in terms of quality outcomes will never be anything more than table stakes. You may move to a different level in terms of outcomes and really advance something, but it won't take long for the rest of the organization to follow suit. It's the nature of our business. We tend to share a lot of information and share that with other organizations when we move the ball, which is the right thing to do from a social perspective. What will differentiate organizations will be service and all the other things that we can provide to the patients that allow us to differentiate ourselves. So be able to move patients through our health system in an effective manner, kind of the Mayo model to some degree, I think is what's going to differentiate hospitals. And these payment systems, I think, are going to be, again, another tool to help, guide organizations in the way that they change the way they think about caring for patients. There's a lot there. I threw a lot there, but I think it kind of pulls a lot of things together.
Brilliantly said. Grace, any parting thoughts?
Yeah, I think I like the discussion on the differentiator, and I think much like technology doesn't equal culture, leadership and people equal culture. The differentiator, it's not going to be process here. I think it's going to be people. And one of the things that I'll say from a manufacturing standpoint, the level of investment as it pertains to dynamic people in these roles is very clear to the manufacturer. And I think as we find, dynamicism meets dynamicism, that's where you're going to meet that differentiator. So I really like what you just said, Gary. And so the one thing I've loved about this call or any of the calls through SMI has been the sharing of process. And I think it's extremely empowering.
Sarah.
So I want to close by saying, I didn't really know what I would find out when we started this study. I was a little skeptical. I'd heard about some of the technical problems that organizations had with bundles in the past, and I was really impressed to hear about how organizations had used this as part of their stepping stone into value-based care, how patients were able to change their expectations, that money was saved, and that outcomes certainly weren't harmed. So I think it's great to see a story that, even if the savings aren't gazillions of dollars, it's definitely the step in the right direction, and it impressed me a lot of some of the stories we learned from organizations.
Right. Just my 2 cents for what it's worth. I think my view is that very quickly we have to, as a value chain, we have to make a concerted effort to figure out whether this is a step in the right direction. And if it is a step in the right direction, I think we have to catalyze how we get there faster than what we already have been. Because to everybody's point earlier, to Sarah's, to Gray's, to Gary's points earlier, I mean, the benefits are there, but I think we've only been touching the tip of the iceberg. And in order for us to really, really get into the make it rain money, so to speak, we've got to wrestle the bull down with both hands rather than our fingertips. And I think that's where the right investments, the focus, and the culture piece absolutely come into play in spades. With that thought, if anybody wanted to throw virtual tomatoes at me, I think there is an option there too. But,
Hussein, this is Dennis, and I want you to know there are no virtual tomatoes in the webinar technology. But, for Sarah and Hussein and Gary and Gray, it's been a fascinating conversation. I think we're all experiencing that, these bundle payments are changing our alignments and relationships with caregivers along the continuum of care, depending upon where you are. And requiring more collaboration and so forth, and it's all seems to be something that's here to stay. We really appreciate that you folks were able to share your time with us and your thoughts with us today. I want to remind all of our attendees on this webinar that when the webinar concludes, you'll automatically be brought to a survey that SMI has as part of the program here. We'd like you to complete that survey. And then later today, all attendees will receive a copy of these slides as well as a link to the report put together by Sarah in the Deloitte Center for Health Solutions. We thank them for that as well and for their support of this SMI to You webinar program. With that, we're going to conclude today's sessions. And again, thank you to Sarah and Hussein and Gary and Gray and to everyone for participating today. I hope you have a great rest of the day. Thank you.
Thank you.
Thank you.
Thank you.